Thank you, Dr. Kuzimano. I guess, Dr. Ravi, the joke is on me because when we try and split this area into neoadjuvant into adjuvant, I think you have kindly delivered half of my talk. So, but I guess it shows the power of persuasion that RJ has. So when he asks, we try and come up and slice this cake as much as we can. So thank you, RJ, for the introduction. These are my conflicts of interest. So the objectives, it'll be very apparent to you that there's only two lines there, and there is the vast area of emptiness reflects what we don't know about this disease. I hope to just cover a bit more on the basic epidemiology of primary cardiac tumors, and probably with the slant of how we treat this disease in Toronto, give you a bit of an idea of what we do from a neoadjuvant adjuvant perspective. So, as we have heard earlier on, primary cardiac tumors are rare. They're mainly benign, but for the malignant diseases, this is where the focus of the conference is. In terms of malignant cases, they're mainly sarcomas. They can be any type of sarcomas. I think that's the take-home message. There are preponderance to some tumor types. Most case series shows angiosarcomas. Like Dr. Ravi, I've put in the more controversial subset, which shows intimal sarcoma is perhaps also one of the commoner subtypes. The clinical presentation, as we have heard earlier on, will depend on location, size, extent of the tumor, which is, mainly physiological, and we can explain this. And despite everything that has been said and will be said, in the localized setting, complete resection still remains the treatment of choice. Despite the successful approach to local treatment, i.e. in terms of complete resection, many of our patients experience relapse, often with metastases, which highlights the problem with this disease because it's truly what we think is a systemic disease. Thinking of this as just merely a local disease will not cut the mustard. We really need to think of this, that this is something that has got high propensity to go elsewhere. The appreciation of microscopic disease has to come into the consideration of the treatment. Because of the dismal outcome of these patients, despite poor evidence base, or rather lack of evidence base, I should say, in many centers, this has led to the use of neoadjuvant chemotherapy. At the moment, there is no randomized data. In fact, there is no prospective clinical trial in this setting. And a lot of these practices are based on published retrospective series. Clearly, that has been demonstrated by Dr. Ravi earlier on. Despite this approach, overall survival remains poor for many of our patients. Average overall survival, if you take this as a whole group altogether, is often about a year. If you look at the curative setting, Dr. Ravi have shown that this is perhaps approaching the 2.5 year mark. But if we are calling long-term survival on average of 2 years, it shows you the magnitude of failure that is in our hands. The long-term survival of the resected patients, if you look at, the mark of more than 2 years, 4 or 5 years, what is considered long-term survival for many other cancers are really appalling. It ranges from 1% to 8%. Better outcomes perhaps have been seen in younger patients, absence of metastatic disease, perhaps the use of adjunct or neoadjunct therapies. But as earlier stated, R0 resection seems to play a critical role. Due to the rarity of the disease, referrals should always go to high-volume centers, and a multidisciplinary approach must be done at each time point. Here in Ontario, we are in some ways lucky because anytime the term sarcoma is being used, it triggers a centralized approach. Charles, who sits here within the audience, is the head of CCO for sarcoma, and if that doesn't happen, usually we get reasonably antsy, right, Charles? But the thing is, this type of approach should really happen on an international basis, regardless where the patients are. And I think that is one of the vision of what RJ has with, the bringing in minds together in meetings like this. So how do we deal with cardiac tumors in Toronto? So at presentation, patients will have diagnosis, and the diagnosis must include tissue. They get staged. The staging that we do is slightly different to how they do it in Houston, for example. We don't do much functional imaging, and in the past, this is due to lack of access. The good news is that in the last year or so, the uptake of PET in sarcoma has been increasing. We are getting gateways on how to do this. When I first started here about 5-7 years ago, I didn't used to image the brain, but I think the realization of how this should be managed really comes very quickly, and we include MRI brain as standard now. Upon diagnosis of a malignant tumor, they automatically get discussed in a multidisciplinary tumor board. We have a sarcoma-specific tumor board, and RJ also kindly discusses it with the Pan International Tumor Board that is hosted at Dr. Ravi's institution. And our usual approach is in early stage, if the disease is localized, we give neoadjuvant chemotherapy, and hopefully after that they can get to surgery. And my argument here is that if we see a case, and we don't really see this because the way things have happened within our province, but for whatever reason, if surgery has been undertaken first, I still argue adjuvant chemo should be given because of the realization of this is a systemic disease, and I'll try and rationalize that as we go along. We don't routinely give adjuvant therapy if neoadjuvant therapy has been given, but if surgery has taken place without neoadjuvant therapy, it causes us a rethink how we do this. Radiotherapy is infrequently used, but in the metastatic setting, usually, up to trimodality employment of treatment can happen. One of the bigger differences now, especially with the oligometastatic disease, is that unless we have superb response to chemotherapy, i.e., almost complete resolution or complete resolution of the mets, we don't proceed to surgery as we did before, because I think the realization that, the competing risk of death lies with the metastatic disease, even in the cases where you get initial good responses. What does chemotherapy entail? It usually includes adriamycin and ifosfamide. We are less adventurous than only by 1 gram per meter squared. And if we have to use gemcitabine and docetaxel, our docetaxel dose is slightly low as well at 75.
We use 75 as well.
All right. Okay. We use the time gemcitabine. We just find at 75 it was already tough to deliver for 4 to 6 cycles. Moving forward, so really, in terms of adjuvant therapy, I try and put a Canadian flavor there. I don't know whether I've hit the mark. But, our approach is slightly different because we don't usually give adjuvant therapy. So the management of cardiac sarcomas is contrastingly different, at least here in Toronto, in soft tissue sarcomas to other sites. Our usual standard of soft tissue sarcoma approach usually includes for low-risk disease, surgical excision alone. For high-risk disease, perhaps the use of neoadjuvant radiotherapy and surgical excision. And as standard, we don't use neoadjuvant chemotherapy usually. Chemotherapy may be used in select cases, usually as a trimodality treatment for these non-cardiac sarcoma cases. And the basis of that is that, one of the stronger evidence is this SMAC analysis in 1997, which shows really chemotherapy doesn't prolong your survival across many different disease types. We are aware that, a subsequent meta-analysis perhaps shows some benefit. But on the same token, when you include a later trial, which is one of the biggest studies done by the EORTC, we do not think the use of chemotherapy actually prolongs survival. So, why are we different in terms of primary cardiac sarcoma? It comes back to the fact that we think that this is truly a systemic disease. And unless we try and tackle this systematically, surgery alone is not going to be enough. So, why use neoadjuvant chemo? I think Dr. Ravi have eloquently put that through. There's a value for cytoreduction because of the location of the tumor. We really want complete or better resection. And there's evidence as well that if you couldn't get people to better resection rates, their outcomes are poorer. And this have been discussed many times. Within our group, we actually have also shown that this is true. This involves 5 or 6 different institutions with 61 patients. And we've shown here by this table here that when people don't get surgery, the outcome is much poorer when they get complete resection. Of course, there is bias. This is a retrospective series. People who are evaluated, are retrospective in nature, and you don't get a sense whether this is truly a cause and effect, if you like, or rather, I think it's rather an association. But what is startling is that in this analysis, we wanted to look at how we treated this disease previously and now. Despite whatever evidence that we have said, the outcome of these patients have been equally dismal over a period of time. The value of chemo in terms of adjuvant or neoadjuvant setting, if you look at the published series, it's about 10 of them. The data is really a dog's dinner because it contains a lot of information, but when you try and tease the true value of chemotherapy, it becomes very difficult. The few that I've selected here, and there are people within the audience who are authors of this, probably will show what Dr. Ravi have showed earlier on, is that with increasing use of chemo, perhaps our survival is increasing. If you look at magnitude of benefit, you can argue that sometimes in some series you can quadruple or quintuple the survival rates, but the survival rates overall remain poor. But what is interesting as well is that when you try and tease neoadjuvant and adjuvant, it becomes even more difficult. So as I stand here, I got to humbly say, if you want me to point a good series to show why we should use adjuvant, I don't think I could. But the argument for adjuvant therapy stands with how we want to give neoadjuvant therapy as well. I don't think those are particularly different because we've got to approach this as a systemic disease. Where the bigger problem, I think, is that there is poor outcomes despite successful chemo and surgery. What we think is good reduction of tumor, what we think is good surgery, i.e. RO. The question is, are there select patients who will need further treatment? And this question is not clear in my mind. And the concept of, as we think this is a systemic disease, are there patients out there with minimal residual disease that we otherwise are not detecting? We also have poor understanding of the biology of the disease. We don't understand its true clonal evolution, what treatment pressures do, why do they respond very well for 4 months and then it blossoms up again. And there's a variety of host and tumor issues that we need to find out. The field of genomics, proteomics, and metabolomics, we would argue has, I'm looking at Brian there when I say metabolomics, but what I'm saying is that this field is moving fast, but in the space of primary cardiac tumors, we really haven't made any headway. So I think there is low-hanging fruit that we try and seize and exploit opportunities, especially within, a more global collaboration. We have a study at the moment called DNAZA. This is led by our radiation oncology colleague, Dr. Schultz, as well as myself. And our fellow is Owen Malone, who's sitting at the back. And we collaborate with a number of our scientists, both in Mount Sinai and Princess Margaret. But basically, we wanted to look at longitudinal evaluation of circulating tumor DNA in high-risk extremity soft tissue sarcoma. So these are people with soft tissue sarcomas that we usually don't give chemo. They get radiotherapy and surgery. We try and collect their bloods prior to radiation, after radiation, before surgery, and after surgery longitudinally. We will sequence their gene at the point of biopsy when they were first diagnosed and try and follow them up according to specific gene signature. So we have to make custom ctDNA detections for these patients. We have done the first 12 patients. Their data is being sequenced at the moment and being analyzed. But what I'm trying to say is that for these type of patients where we have been looking at people who are getting radiotherapy and chemotherapy, despite this complex pathway of getting things done, we certainly should think we should really think of including primary cardiac sarcomas here, because what we would do really is try and use the diagnosis sample as your primary reference sample. When they get chemo, we can follow them with ctDNA, and then if they get surgery and after. if our hypothesis is correct that there are people that perhaps have got still minimal residual disease, perhaps these are the people that we want to give adjuvant therapy, even in the respect of they might have neoadjuvant therapy up front. So this is going through hopefully an amendment soon to include primary cardiac sarcomas. So other projects of interest, I think Dr. Farouk and Dr. Gupta will speak about national and global databases. This is upcoming presentations. I look forward to this. We really need to understand biology of disease, comparison of the biopsy versus resection versus metastatic tissue. I think, you were saying that, Ravi, you have got a big collaboration with China ongoing with that, and we look at opportunities to collaborate with you. And there's also single-cell studies now that can occur. So one of the things me and RJ is trying to set up is the use of a platform called Parsotics. This is circulating tumor cells where we try and look at single-cell studies as people are being treated. So, as always, opportunities in these type of projects are valuable, and we here in Toronto will always look to collaborate with any of our investigators, colleagues. So, in summary, I hope to drive the message that sarcomas are rare. They have to be treated in high-volume centers and multidisciplinary approach, and sometimes it's not local, but international is a must. Cardiac sarcoma should be considered as a systemic disease. Therefore, the use of neoadjuvant chemo should be considered as standard despite the evidence base that we have. There's an unmet need to identify why patients have metastatic relapse despite initial successful treatments. And due to rarity, our research efforts need to be taken on a global basis. With that, I thank you.